So now a few words about how to handle these samples. So first of all, what are different types of samples we do get by these procedures? One is the aspiration smear. The aspirate can also be used for cell block. Then we have tissue samples like transbronchial lung biopsy and endobronchial biopsy samples. So the fixatives, the smears can be air dried or it may be fixed with 80% isopropyl alcohol. For cell block, we use cytolite as a fixative. Then for tissue samples, we use 10% neutral buffered formalin. Then the stains, for the transbronchial aspirate, we use rapid stains like rapid HND, right Jimsa, and modified rapid PAP stain, whereas routine HND or special stains can be performed on the cell block or tissue sample. Now, a few words about tissue processing. TBNA slides are processed for rows. All stations are stained with rapid HND. The screen for the pathologist will screen these smears for adequacy, then representative cells, and for diagnostic CT. Then the aspirate can be used for cell block. Both cell block and tissue biopsies are processed with routine methods. Then on these samples, we can perform ancillary tests like special stains, IFC, or it can also be subjected for mutation study as and when required. Then few words about rapid on-site evaluation, otherwise called as ROSE. It is nothing but screening of TBNA smears by pathologists in bronchoscopic room. The main advantage is to reduce negative or non-diagnostic sample. So the advantages are to use specimen adequacy for final diagnosis, to identify target organ has been sampled or not, and to optimize the slide preparation and specimen handling. Then direct sample collection for ancillary studies like microbiology, flow cytometry, and cell block. It provides a preliminary diagnosis for the pulmonologist to manage the patient till they get final diagnosis. So a few words about staining. In our center, we use rapid HND for all rows samples, and the fixation is about 15 seconds with isopropyl alcohol, and emetoxylin being the longest duration, which is around about 1 minute. So once the smears are stained, then it has been screened. It has to be screened by pathologists to know the adequacy of sample. There are 4 criteria that are used to see the adequacy. One is the core should be more than or equal to 2 centimeter. Second is presence of malignant cells, at least about 300 cells to be present in an aggregate sample to call it is adequate. Then there is presence of microscopic anthracotic pigment, and the last criteria is lymphocyte density, where the lymphocyte count should be more than or equal to 40 lymphocytes per HPF. Any sample which is not meeting these criteria will be labeled as inadequate sampling, and the patient might be subjected for repeat sampling. Let us move on to understand the workflow of EBUS TBNA, TBB, and EBB. As I said, when the aspirate is done, the aspirate is placed over the glass slide. The tissue fragments are picked up and they are put it in 10% neutral buffered formalin, and the aspirate smears are stained with rapid HND and they are processed for rows. And these slides are reviewed by pathologists, and a preliminary diagnosis has been informed to pulmonologist. Rest of the slides will be sent to, and all these things will happen in the bronchoscopy room. So once the preliminary diagnosis is informed, then rest of the slides are sent to the department where they are stained with other stains like MGG or PAP stain. All the cytological findings are documented. Then the tissue sample, whether it is a cell block or a core biopsy or it is EBB, TBB, they are processed with routine method and they are stained with HND. If required, special stains can also be performed. All histopathological findings are also documented. Both cytological and histopathological findings are correlated, and a concise diagnosis is offered to the patient. Now, this is one of the article which was published in Mediastinum regarding the impact of ROSE on diagnostic yield of EBUS TBNA. Geo et al. In 2016, he concluded that better diagnostic yield in ROSE group, which is about 90.5%, than in non-ROSE group, which is about 81.2%, where the p-value is 0.003. And later, Kopana et al. In 2020, he concluded that ROSE diagnosis was concordant with final diagnosis in about 96.1% of the cases. And Joseph et al. In 2013, he also stated that the sensitivity of EBUS TBNA is about 92.1%, whereas specificity is 100%. So this gives us a clue that this EBUS TBNA and the ROSE is a very good procedure to analyze the tissue sample and for initial diagnosis. Now, what are the challenges that pathologists will face while handling small biopsies? So this is a real challenge. So the first one is diagnostic limitation imposed by partial sampling. I think this we every day we encounter in our clinical practice. So when the sample is containing abundant necrosis, hemorrhage, or if it is mixed with mucus, or only plenty of benign bronchial epithelial cells, or the epithelial cells with the reparative or ATPR may be either underdiagnosed or overdiagnosed. Then role of IHC markers in diagnosing malignant tumors. The IHC is indicated only in the patients who have been labeled as non-small cell lung carcinoma (NOS), where the squamous or non-squamous histology is not definite. This is in order to save the sample because we are handling small biopsies for further ancillary tests. The third one is conservation of tissue sample for ancillary tests. This is important in cases of non-small cell lung carcinoma, particularly the patients with adenocarcinoma histology, where these ancillary tests like mutation analysis can be done for targeted therapy. Then last but not the least is approach to cases with non-specific findings. I think this is one of the gray area for the pathologist where we cannot conclude any definite diagnosis. In such cases, these cases are discussed with the MDT, and we should decide upon whether the patient should be subjected for repeat sampling or should be kept under observation with close monitoring.